starts 2027 and moving forward is going to be very a dynamic shift in a way, right? Because there are three things happening. You have excellent healthy outcomes for all. Let's unpack excellent healthy outcomes for all. Like if you can just give a high-level overview of like what you see are the key components of this.
So far, the new administration changed the naming of it, but they haven't really changed what it measures. And it basically is looking at a plan's performance with members with specific social risk factors. And those social risk factors are going to be based on low income, established by being a dual eligible or low income status member, and disabilities. And so it isn't about race, ethnicity, language, all the things people think about when they just describe health equity in general.
What do you see right now, some of the best practices plans are doing right now? And what do you see are several areas that plans can do not only this year, but also throughout the year next year in this?
It sounds simple, but plans are not always measuring this on their own. So that, there's vendors that can do this, you can do it on your own, but you actually have to create your own dashboards for this performance. I would suggest that you need to lean in on social services, community connections, having relationships through your case management, population health programs. I suggest plans sort of track this performance, look at ways they can connect with them.
Welcome back to the Healthcare Starcast, where we go from beyond ratings towards excellence. Today, I have Dwight Pattison with me, founder and principal advisor of QP Advantage. Welcome to the show, Dwight.
Yeah, thanks. Great to be here.
Yeah, very excited to talk to you right now, especially in this time of the year. It's almost November right now. It's been 2.5 weeks since the star ratings released in Medicare Advantage. So it's a generally defining moment in a way in healthcare for the overall calendar bit, right? So you have annual enrollment for Medicare Advantage already started. Despite the government shutdown, CMS is pulling furloughed workers to kind of support enrollment. So there's going to be a lot of work needed. So we're not going to talk about the government shutdown, but at the same time, all of these impacts here, AEP just going to start for Affordable Care Act November 1st. And star ratings were released. For health plan executives, it's a mix of anticipation, relief, and sometimes shock for people, right? Budgets are shifting, strategies are questioned. You and I have been in the boardrooms answering those questions. Futures are calibrated. But the real challenge and what we want to talk about today is now what? Where do we go from here? But before that, Dwight, I've known you in the industry. We've collaborated. But for my audience, if you could just give your background, what you're currently up to, what kind of cool things you've done in the past, that'd be awesome.
Yeah, sure. Yeah, I've been working in healthcare quality and performance reporting for about 20, 25 years. The last 12, I've worked as a consultant for health plans and vendors and provider groups who are concerned and interested in their performance. My background is everything from, working in behavioral health, product programs, small health plans, large health plans, and I ran United Healthcare's Medicaid division's HEDIS reporting for about 7 years. So big plans, small plans, everything in the between. And my last job was actually at a startup building a whole new program. So seen it all, been around, so I really enjoy now just sort of diving into problem solving and working with plans to improve their ratings and HEDIS reporting.
Excellent. Dwight, in the Medicaid space, in the STAR space, we have collaborated back in the day. And two important topics that I really want to double down for the audience today is really thinking forward on some of the big shifts in the quality world, and not only in the star rating world for Medicare Advantage. But before that, 2026 star ratings released,
Yeah.
right? We had our own kind of like idea of like where things will land, and it's a very, as always, it's an interesting time in Medicare Advantage, and now there's a lot of exits, consolidations going on, people entering into DSNP a little bit more. Some states actually also kind of forcing DSNPs to happen. So what are your thoughts? It was interesting.
Yeah.
Yeah.
It's an interesting, challenging year for Medicare plans. A lot of folks talk about budget cuts, budget changes, reorganizations, staffing changes, leadership position changes. All amongst that, it affects sort of stars. So when the stars came out, to be honest, I think the big news is that it wasn't as sort of groundbreakingly shocking to plans this year. It's not that it was better. It was still not a great year for most health plans, considering you look at the last 3 to 5 years. But what happened is most plans sort of properly predicted where they stood. And now they're sort of like, we're still not where we want to be or where we need to be. So how do we get out of that trouble? And so there are plans that are fighting and scraping to try to still get involved in like how they perform. And I think that's what we see. For me personally, I'd say the plans that I'm interacting with are, they're more worried maybe for next year's scores, at least the ones that are reaching out to me, because of changes that keep happening. So there's more changes to come, some more downward pressure. I think next year will be a harder year than this year for a number of plans, and we'll see how that goes.
Yeah. And it's interesting. It's very similar for me as well, right? I mean, I think I recently came from the health plan world. So, I mean, uh, there are plans who missed star ratings by 0.0043. Like, I saw a lot of those scenarios. There are unspoken scores in the results, right? Oh my God, like it's really close ones. You probably have seen that too. Um, but anyway, so we're not going to deliver, go into the past. This is rating
Sure.
that happened, right? But it's always interesting in the industry how the analysis happens. But let's dive in, right?
Yeah.
In my opinion, stars 2027 and moving forward is going to be very a dynamic shift in a way, right? It's because there are three things happening. You have excellent healthy outcomes for all, which we'll unpack a little bit here, which is the former health equity index in star and then you have the rewards points, the bonus points that are going out of the window. It's gone out of the window already. And then you have membership shifts happening because plans are shifting. That is actually going to go into the factor into the score a little bit. And you have new measures and all that stuff, right? So your initial thoughts, right? It's a lot to talk about. Your initial thoughts, piggybacking on, okay, it's going to be interesting, next year.
Yeah. I think you're right about the small numbers. Plans have to really get really efficient about where they're performing. The cut point, I had a plan sort of miss readmission rate by maybe 15 people, right? It's 15 discharges. So any measure plan has certain major changes that they need to affect. But with the changes in measures and the reward factor changing, there's a lot of more pressure on the top, where plans that are 5, 4.5 could lose that rating pretty readily and drop precipitously because of the change in points. So I think this is the year sort of like a readjustment. And I know some have already sort of anticipated that, sort of build it into their plan and strategy. They're trying to maybe even change and shift their product releases. So we'll talk a little bit about that with the EHO for All. They're looking to maybe expand the types of members they serve and maybe have SNP products added in order to sort of pursue the population that might get them a better star rating and performance. It's interesting. Something you don't see as much, but they're getting really creative in that.
In that year, yeah, totally. So let's unpack this a little bit, right? It's because there's lots things happening here. So bonus factor for people who are not into the star trenches, bonus factors a reward factor historically has been 0.4 points maximum out of 5-star basis points, right? It's almost like half a star or 1 star in some cases, depending on how it works. That means people are improving year over year on certain measures, and people get bonus points, right? So we've been talking in the industry like the last 2-3 years about this is going away, right? So that is, and think about the percentage of impact, and the big plans who are matured in this, or most of the plans have been matured in this one right now. Right now, like 80% of the plans, I would argue, they're like going for the bonus points and like improving year over year. They've recalibrated the dashboards, right? So over the years, so they would say, you know what, I need 10 more members on controlling blood pressure. Get those starts because it's going to bump up my reward factor, you name it, right?
Yeah.
So it's been in the DNA of health plans, and all that, right? Now let's unpack the excellent health outcomes for all, or the health equity index, right? That's completely replacing as of this year.
We're here.
All the star leaders and quality leaders know about this. This is already codified. It's already there. So stick, at a high level, right? Let's unpack excellent healthy outcomes for all. Like, if you can just give a high level overview of like what you see are the key components of this, and then we'll start from there.
Yeah. So far, the new administration changed the naming of it, but they haven't really changed what it measures. And it basically is looking at a plan's performance with members with specific social risk factors. And those social risk factors are going to be based on low income, established by being a dual eligible or low income status member, and disabilities. And so it isn't about race, ethnicity, language, all the things people think about when they just describe health equity in general. This is very honed in on something that we can measure and understand, and all the health plans sort of have easy flags to identify. So it's going to look at a subset of members in your plan and how well you perform on the same star measures. And then you're going to examine that performance. And like I said, it's low income and disabled. And they could add other factors in the future, which we can talk about. And it's basically, you got to hone in on those people's performance, and it will be, thankfully, the same measures as the standard star measures, like eye exams for our diabetics and medication adherence and CAP scores, satisfaction experience scores, but it's only for the members in those categories that are more at risk for performance challenges. So that's the key. But anything else do you think, Subbu, we should talk about?
Yeah. I know that's good. I think you actually had a really good video that you posted on the detailed methodology. So we're not going to go into the super details of that, but we'll put that in the show notes for people because I think it's a fantastic video. I think I want to jump.
I wanted to say, like, the video was to give people specifications because there's so many rules and guidance. Right. I think most people need to understand that it isn't new measures. It's actually the same set of measures, but for a subset of people. And I would say the other thing is that the new administration hinted at sort of added features to it. So we may likely see rural, non-rural member categories where they might look to use that reward for this new indicator towards getting health plans to focus on certain populations they may not be focused on currently. Yeah. And so that will certainly be important. But we'll keep an eye on that as the next year or two happens, because I think you likely see it shift to something other than what it
other than what the current one is. Yeah, totally. I think we once it comes out, we'll probably put a podcast out there at that time.
Yeah, of course.
But I think just to break it down, right? So it's a complex calculation for behind it, right? So it involves the blending of weighted average across our scores for each measure, right? There's a factor of enrollment, how big or small your plan is. It gets factored into it. It's the factor of how your individual measures are performing. And then CMS is ranking of the plan based on some of these factors. However, I think to your point, the most important factor and the most important point here is these are for existing measures for members who have, with social risk factors, right? Such as simple as low-income subsidy members who need the most care, likely in, community engagement or food on the table, transportation, you name it,
Yeah,
right?
well, think about it this way. Like if you're pursuing a rate of mammogram rate, women getting mammograms, you're competing at a population level. So it's all women in your population. So if the expectation is maybe 80%, 85% is a good score when, that other 15% aren't getting mammograms, right? So if you take it and look at a subpopulation of members that tend to be less compliant, they're looking for you to focus on a population and get their scores up to where the others are or
With
be
the others.
competitive. And I
Yeah,
think I'd go back to the specification is that you're being compared to all the other plans' performance on these same members. It's not within your population and how you do with one set versus another. So you're competing against, unfortunately, like plans that may do better because they're in a certain market and not because they're doing better for those members. And so the fairness of this measure isn't something we could call out, but not everybody's going to qualify. You have to have enough members in these sub-factors to count. And so before, you got the reward factor if you were a high-performing plan. Everyone could qualify as long as you got to a certain performance level. Now, this is only going to give rewards to plans with a specific set of members in their population. And I have clients that were, 4 to 5 star plans that don't qualify for this reward. And they were getting the prior reward factor, which was based on performance. And that drops them a half star or more
or more
in the next year. So
absolutely.
that'll be what's the challenge. Yeah.
Yeah. I'll tell you, like, there are a couple of plans where it's especially a large plan, right? When you're trying to move the needle on from a 4-star measure to a 5-star, it's incredibly hard, right? Because the scale that you need to get to is large. A 1% move is significant. 1% move in like a smaller plan is, few handful of members. That's important, but like a large plan is even more challenging. The scale of it, and to really kind of talk about what you said here, right? So plans have actually historically used the reward factor to improve a little bit. And then you get, as long as statistically significant, to kind of get the next level. So they have aspirations from 4 to 4.5, 4.5 to 5, and all that stuff. So that game is completely out of the window. The other thing is, this is something that I want to bust the myth here, right? Just because a plan is dual and has social risk factors, you're not guaranteed to get those points. You're eligible to get those points, right? Now you probably have seen this as well, right? Because I think people confuse the categorical adjustment index to this one, because categorical adjustment index, it just gives you the points that are based on all the different factors. But here you're eligible for those points, but you got to go earn it.
Yeah.
Right.
But the difference between the two, people ask me all the time, is like one rewards you for just having those members in your population because they tend to underperform. They tend to report certain factors lower, tend to be less compliant in your HEDIS scores and the like. And so this one is going to have you focus on a subset population, but you're compared to other groups and it'll be an additional reward for that. So it's performance based and not everybody. So I'll go back to the idea. It's like not every DSNP's high performing, right? There's a lot of DSNPs that do really well globally because they have a shared population between non-duals. DSNP is dual SNP members. But then for these other plans that are adding, they're looking to add a DSNP or a CSNP or look at benefits that attract more members that have low income, disabilities, so that they will qualify for the reward, but they're not prepared for the work it takes to work with those members and the populations, because it isn't just do the same thing for the same number of members. No, it's have programs that actually connect with those members, help and provide them solutions to their barriers. Like if they're low income, more transportation, or maybe they're in a region where your provider network isn't as solid. So you actually have to look at access. So there's a
Yeah.
lot to unpack there.
Yeah. So I think let's talk about that, right? Because I think you covered like from the beginning to the, the structure, framing it into the actions, right? So um, it starts with identifying members, right? Identifying the right members, calculating, but obviously, calculating how it will impact eligibility, right? The thing you mentioned there, mentioned removing barriers, connecting resources, all the things that we talk about in healthcare, right? Beyond the clinical care, um, network adequacy, community programs, and doubling down on this, almost all the healthcare organizations are in this mission, right? It's really doubling down in the, on that mission in a very targeted way, right? Um, what do you see right now? Some of the best practices plans are doing right now, and what do you see are several areas that plans can do not only this year but also throughout the year next year in this? I know it's a loaded question, right?
No,
But
I
you
mean,
can actually
it's
take
value.
your time from the beginning to the end.
It's fine. Oh, we've been warning plans for a couple years on this. It's a 2-year rolling measure period. So it's actually the first measure period will represent 2024 and 2025 measurement period. So we're way into it already. I think that first and foremost, it sounds simple, but plans are not always measuring this on their own. So that, there's vendors that can do this. You can do it on your own. But you actually have to create your own dashboards for this performance because it's all measures that have member-based calculations so that you can break up by these populations. And you need to know who they are. And then when we talk about interventions, I come from a Medicare and a Medicaid background, and I would suggest that you need to lean in on social services, community connections, having relationships through your case management, population health programs. You're trying to bridge to the facts. So if they have a disability, are they able to get out of the home? How easily? How difficult? Do you have to bring services more closer to them? If there's low income, like I said, things like getting access is a major problem. And if your network may be adequate in general, but maybe inadequate for those members. So I suggest plans sort of track this performance, look at ways they can connect with them. But what I hear often is like, oh, we're going to do more reminders, or we're going to send out letters and notices just like you do for the whole population. And I think it's inefficient, and it's not going to be effective as what you need to actually change performance.
Yeah, totally well
Yeah.
said. And it's just also like waste of resources in a way, right? I mean,
Don't spend the
waste of
money
dollars.
on something that's not going to have a bang.
Yeah.
Yeah.
And it's a very traditional method. 10 years ago, like absent care kind of closure, right?
Yeah.
So on that point, you see cross-functional work. That's one of the things that you're talking about here. So that's exactly what I also advise here, right? So one of the things with low income subsidy, and you were in the trenches of like how CMS sends the data.
Yeah, sure.
Often the risk adjustment team, has the data much more, and they know, for example, somebody from risk adjustment listening to this, going to the MMR, and you have the risk adjustment factor type, you have all the different eligibility of those members, whether it's members a low income subsidy or not. Not many plans have that information reconciled with the HEDIS teams and STAR teams. It's a gold mine.
Yeah, and Subbu, one of the things I keep banging the drum about is that like the LIS factor flag is one of the statuses that put them in the measure for the reward for EHO for all. But it's also a factor for a lot of other measures. And it's case mix adjustment for CAPS. And it's actually going to be involved in your future pharmacy adherence measures, since that's going to be all recalculated, and people have to look at that more closely.
Yeah.
So the plan that does well, first and foremost, will examine whether it's accurate. And people don't realize this. 2-3 years ago, I can't remember. I'm lost my timeline. There was quite an error in those reports, and we just sort of nobody really audited their CAI factor and their other. But it's time to actually start with just validating that you have all the members flagged correctly, so and that CMS is reporting it accurately once you get that data, because these are even smaller numbers in your overall population. So a handful of differences could be huge for any one plan.
Could be huge. And then to your point, like the people who are the denominators and enumerators in terms of inclusion and exclusion of these measures, right? So people are in ESRD. It's a classic case, right? People who are in ESRD hospice are not involved. So typically that sits in the encounter data within, the risk adjustment side, this reconciliation needed. So I think this is where lots of help needed to kind of like bring the pieces together across cross-functional teams. If people are hearing, Dwight is here, I'm here, we'll reach out to us, to see how you can connect the dots here. This is just not one and done. This is, as Dwight mentioned, multiple years of work. So even if plans or providers and others are listening, if you're behind, it's okay. It's okay. You're behind because of various reasons.
So are others. So you're in with them. Yeah.
Yeah. Right. Exactly. So I think the takeaway here, Dwight, right? Reflecting on this, it's educate first, because it's actually, many of the stakeholders don't know this because they don't actually live in this space that much. Obviously, mention about the data part of it, updating the dashboards, eligibility. We talked about trends and all that. So that's a takeaway here. Check out Dwight's YouTube video if you want a technical refresher. But this is a conversation worth having. This is actually the work that is good for the members in the community. That's actually one of the things I'm juiced up about this.
I mean, it is great. Like these people, the reason they're selected originally was because they underperform. And also it's a competitive advantage to do well in that population because your overall score goes up. So you don't just raise the reward factor points, you're going to raise your overall score and be more competitive across the board. So it actually, solving their problems will solve your organization's problems. And then there's a whole downstream effect that's positive for the member.
Yeah. Excellent. Well said. I'm going to transition this a little bit. I know we talked about this is a big part of the star changes over the next few years. Let's talk about digital quality. So that's one of the ones that I want to double down on, right? So obviously with HEDIS and other things, digital quality is actually, we're talking, not only on Medicare Advantage, but like the overall populations, whether it's ACA commercial, whether it's Medicaid, it impacts all of it. Quite often a challenging topic, right? I've had board members and others and other cross-functional teams like, what the hell is digital quality, right? What do you mean digital quality? So let's put things in context, right? So the way that digital quality are standardized digital representations of healthcare quality. So basically, simply said, you cannot, if you pull facts of a medical record of A1C measure, A1C value of a member, and like load that data manually into a HEDIS system and submit it to your regulators, and that measure counts as, okay, yeah, Subbu Ramalingam got a A1C. That's not digital quality, right? So digital quality is really standardized set of technological standards that actually goes into, that comes from a EMR, comes from HIEs, and then goes in a structured manner through, and submitted to NCQA. You've been on the plan side. You've been on, on the on multiple side. Paint a picture for the audience, Dwight, right? Back in the day and to now.
Yeah. So, yeah, I started when he just wasn't even audited back many years ago in reporting. So let me give you a vision of like what the future is and what digital quality is supposed to represent. The concept is that data flows equally between payer and provider and member and others, right? So that we all have the same knowledge and clinical information about that one individual. And we can make decisions based on that. So digital quality is that we all just run the same program language and we generate the population rates and we get the same result. And what happens now is if a payer wants to know if someone has services done, they check claims, but there are historical services that fall out of claims or they got to paid out of pocket, other insurance, you name it. And digital quality's idea is like, well, whatever the provider knows, the payer knows, and what the payer knows, the provider knows, and we can just generate measures like that. And then what the member would open up their phone and through APIs, they're going to have the same knowledge. So instead of like the payer saying you're non-compliant, then the provider says, oh, the member's compliant. The member says, I already got my mammogram 3 months ago. Like everyone has the same story. But to make that work, data will have to flow evenly and equally and rapidly between these entities. And it's just not that the case right now. So what we're doing when we talk about digital quality for plan performance now is we're being forced to move quickly in how we produce data and results when we don't have that dream world where data flows equally and evenly. And so that's the crux that we want to talk about maybe today, is that there's an expectation that, hey, you're going to produce measures in a certain way. You're going to collect data that you don't have currently, like depression screenings that don't come through claims. And now we're going to be in the middle ground for quite a number of years. And so there's a lot to talk about as to what you could do or what might happen through that process. So hopefully that helps.
Yeah, exactly. Yeah. And I think the path really, right? It's, as you said, from traditional quality measures are based on data from claims and paper.
And doing medical record review. We used to do it on paper, right? We check everything and send out a nurse to the office and get the record out and look at it.
And like, and then it's codified with whether you found a blood pressure rating, etc. Then came CQMs, right? ECQMs, and then digital quality, as you said, is standardized data models that are used from electronic health records, registries, etc. But what's interesting, Dwight, right? I in my roles, I talk to members a lot, right? I call members and kind of like, hey, how's you? Every 3 months I would make, a few calls here and there. Many things that I hear from members would be, don't you all talk to each other?
Don't you know this? Yeah.
I just went to this doctor, like, don't you all know, like, you are always like asking my doctor to send my medical record. Like, don't you all know, don't you all like all talk to each other? So just taking this on an outside in perspective here, right? So, so for folks who are actually not in the trenches within a health plan or a provider, you know what? This is supposed to how it happened, but we're not there yet, right? We're not there yet. I think, so that's the transition. So let's talk now, since we level set what that is, right? So NCQA posted, it has we'll put it in the show notes, right? The digital quality, it's several pages and like FAQs around this. People can go read it. I'll tell you, not many people read that. It is it is out there. It's a website that has all the information about digital quality. If you are new to healthcare or not, if you think that quality team is the only team that actually does digital quality, you got to go look, go read the website.
I'd also say CMS put out a roadmap. It's a pretty long, extensive PDF explaining what the vision was and what the steps would be to get there. And then NCQA is sort of coming in alignment to that pressure over the years and sort of pushing it further. And they definitely have videos and other ways you can learn directly without having to go anywhere.
Without having to go, yeah. Now, this is the one thing that's super exciting, right? So, I mean, we talk about, AI, right? There's lots of hype. There are some good uses right now in scribes and stuff, which, in radiology, that's taking a lot of traction. But in order for health, AI to really work well, it starts with the right data here, right? So, and the data needs to be digitized and organized in a manner that a machine can understand, a human can understand, also without manual effort. So this is a roadmap to get to an organized data set of our entire population or a health plan population, whatever the systems are getting access to, where there's a possibility that a meaningful and the rightful use of AI could make a huge difference
Yeah, of
here, right?
course.
Could look at for patterns, look at machine learning. Right now, it's impossible to get any meaning because data is so scattered because it's not in digital quality format.
Yeah, I mean, you use an AI tool or an analytics tool to evaluate your population as a payer or a provider. Like, you have limited knowledge, and so the tools will have limited knowledge. It's I talk a lot about, like, we can talk specifically about like how NCQA HEDIS reporting will have to be collected and tracked over the next few years, but just globally, um, plans and even provider groups, like, they need to think of this as a competitive advantage. Like, data and information is your advantage, and if the more you know about your members and patients, the more you can actually serve them faster and better and completely. So you're not wasting time with the wrong members. You're not bothering them for something that you should know. So what I put it out is, like, several years. I mean, there's a vision of timeline where data is sort of digital quality, which is 2030. It's not very far off.
Not far
But
off. Yeah.
conceptually, ahead of that is the more a plan can step back with their CTOs, their other departments, their across functional area to say, we need this data for our new members, and we need data for their measurement, and we need it for risk, and we need it for case management and population health. So let's work on ways to make data interoperable with group by group that we work with. And even if you're way behind, if you start thinking about the fact that there are data elements and things that you need to start collecting, map it out and create a roadmap for yourself. And step by step, the more you get in hand, the better your programs will work. And you can prioritize that based on stars or, quality measurement or risk, or just globally how the health plan might want to perform better for satisfaction and retention. So I just say that this should be within your top 3 priorities as a health plan, is to look at ways to obtain the clinical data that's not in claims, that's going to serve all these purposes, and then create a roadmap to collect and in meaningful ways structure it so that you can report it in a good way. And
In good way, yeah.
it's going to it takes resources of time. It's going to be costly, but competitively, the big guys are doing it. So you're going to it's going to become table stakes at some point. And the plans that succeed will have the data on their members and their patients to perform better, and will be more popular and more successful with AI tools, with analytics, with programs, whatever. And I think that's the whole point of digital discussion, is that it is about, we can talk about structure and formats and how data will flow and how complicated that is. But realistically, it's just how much more data can you get now than you had before, and moving towards a stepwise process for that.
Yeah. That's perfect, from a health plan perspective, right, right, and also provider side. So I think one thing here is the acquisition of clinical data, but there's the bi-directional component of clinical data, right? So providers, it's a lot of work. It's a lot of work to kind of like really kind of work with the EHR systems and technology to kind of send the data out. And what's in it for the providers as well, right? So if you're a provider listening to this, or a health system leader, you're probably already kind of working with your health plan. But apart from when they're asking for the data, also bi-directional, how can you help in whether it's in the workflow of your physicians, whether It's showing, okay, member Subbu is low income subsidy, right? I want to let you know, health plan, this member is low income subsidy, right? So it bi-directional would be critical. I know, I'll tell you, there are like bi-directional contracts happening. For example, in the Philly area where I am in, you have Epic bi-directional data going with the 3 health systems, and a couple of health plans. But that takes a lot of work, 2-3 years of contracting. But it is worth the effort. But at the same time, to Dwight, your point, is if it's hard, talk to your folks. Talk to your folks and see, like, there could be efficient ways of interchanging clinical data bidirectionally.
Yeah, so think about all the lists that go out from health plans on gap lists and files and check these members and do this. We need to come up with a simpler way of that. Digital quality would actually allow you to just generate it off the data that you're sent and not having to like get different system gaps. The other thing is millions and millions of dollars and effort are spent on medical record reviews every year. And now
Yes.
it's because of these changes in NCQA, they're doing the annual population-based chart reviews and not just a sample in the spring. So if you can find better ways with your EHR system and your payers to exchange the data they need and the data you need, and these things are getting built by all entities,
For all entities, yep.
not always working, but the more you can do that, the less burden you'll have in those old style ways. And I used to say, like, plans will send people out all year round, get data sent into them, and then they'll send a nurse out to go get the records again and relook at them. At some point, we have to do a reconciliation and say, okay, you don't need this chart anymore. You already have the data off the chart. And by ensuring that's actually true, you will simplify your future efforts and problems. So there is a lot of bonuses coming out of it. And you just have to understand that we're in this middle ground where it doesn't quite work. It takes effort and resources. So start looking at it in ways that, you could pick and choose the kind of data or information you want to do. But the more you can think about this as a 3 to 5 year program of effort, what I hear, it's not my area typically, but, the EHR vendors are working on this too. They're trying to make their tools more useful and understood. And then the government will get more and more regulated into that because of interoperability, but they're going to have to they know if they want this, they actually have to force it on us as an industry because it's costly. And so we'll see how that goes in the next cycle.
With that, like, to summarize that, right? So it's only, it's budget wrap up season for next year and next few years. We're in the middle ground. As you said, things are not perfect. You can't expect perfection in the next couple of years. So it's going to be some blocking and tackling going on, but invest for the next 3-4 years if you're there for the long game. And continue to be nimble to support, through whether it's a chart collection or like, interoperability or bidirectional. So I think as we sit here right now, but just not think about 2026, think about 2027 and 2028 here, because the concepts that we're talking all along, excellent healthy outcomes for all. For stars, it's a 2-year rolling period. It's continuous effort. Digital quality next 4 to 5 years in the foreseeable future here. And this is hard work, working with low-income subsidy people. Sometimes you won't be able to get them in like 6 months, right? Changing is so huge.
Yeah. And I'll just say that the industry needs vendors and third parties to jump in. They're there, but they're trying to overcome the same challenges. And so it will be looking for the right partners in your area and your community and what they can do, and then seeing and telling them what they need. Because I think you probably have listeners that are going to be interested in sort of what is the opportunity if I'm not a payer or a provider. And it is about simplifying data exchange and getting information about members more rapidly. So if it's blood pressures, it's digital machines and it's knowledge about them. And then sometimes it might just be ways that we can exchange between multiple different EHRs back to a pair and translating that data. And there's just a myriad of effort that would be needed. And I think the ROI is pretty readily created. And so you can certainly build those strategies over time.
Yeah, absolutely. Dwight,
Good.
with that, we will wrap. This has been awesome. We've actually partnered in several other avenues, but this is actually awesome to kind of talk a little bit deeper on these subjects. If today's episode helped you think it's going to be helpful, please share. We'll put Dwight's contact and my contact, here. If you're thinking about the next few years, the playbook has changed. You can't use traditional playbooks anymore. Reach out. So really appreciate your time, Dwight.
Yeah. Thank you so much.